Relationships are totally unimportant in healthcare as far as the medical industrial complex. I can tell you that I practice in the oldest family practice in Denver for years. I was the chair of that department. I directed that residency, and I'm now a patient in that practice. I cannot call it. It's impossible. Just when I call the practice, I get diverted to a call center where some very skilled customer service representative asks me who I am, what's my birth date, maybe my medical record number, and then I tell them that I want to see my doctor. I can't get an appointment with my doctor right now for 7 or 8 weeks. This approach to the system is designed to fill all of those appointment slots as quickly as possible. So when I try to call my practice, I'm offered 4 alternatives. Well, we have primary care appointment available at Lone Tree. Would you like to drive down there? No, I want to see my doctor. Well, there's a nurse practitioner who has an opening day after tomorrow at that practice. Would you like to? No, I'd like to see my doctor. Well, if this is bad enough, you can go to our emergency room, and the closest one is. That's what happens. Now, primary care floats on 2 boats simultaneously. Skillful generalists, clinical generalists who know a bucket load of medicine, and longitudinal relationships.
That's Larry Green, a family physician, policy expert, and professor of family medicine at the University of Colorado. Green spent decades caring for patients and studying primary care. So if he can't reach his own doctor, what's the hope for everybody else? I'm sure many people relate to this experience, and the most proximate cause, which Green refers to as the medical industrial complex, is our corporatization and the related impulse to fill primary care appointments as quickly as possible to maximize profits. But it's also important to remember that primary care has been in crisis since long before we became fully corporate. And in reminding us that primary care requires these 2 critical elements, a generalist body of knowledge and relationships, Green's getting at a much deeper problem that he and several experts emphasized again and again to me in my reporting. Primary care has long been misunderstood. Imagine a neurosurgery division where the physicians didn't have access to operating rooms or MRI machines. Most of us would immediately understand that practicing neurosurgery would be impossible. But when it comes to primary care, large healthcare systems increasingly treat it as a point of access to more lucrative specialty services, rather than as a place to develop longitudinal relationships and receive holistic care. So what's the best way to clear up this misunderstanding? There are definitions of primary care, of course. The one I heard most often is that offered by the National Academy of Sciences, Engineering, and Medicine in their 2021 report on delivering high-value primary care. They note that primary care is the provision of integrated, accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, developing a sustained partnership with patients, and practicing in the context of family and community. But though I understand why definitions like these are necessary, when I read these words, especially out loud, I find myself wondering, does this help me or anyone understand what primary care really is? So that's what we're going to be talking about today. What is primary care, actually? How and why has it been misunderstood? And is misunderstanding really the problem? Or is the problem that the idealized version of the consummate primary care physician, the one who knows as much about you as they do your health, simply a relic of the past, a fantasy people like me need to let go of, as we steer primary care as pragmatically as we can into the future. I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. Maybe one of the challenges of understanding primary care is that it often doesn't lend itself to the gripping stories you get from the emergency department or the operating room, the kind of drama and tension that make for good TV shows. But I do think there are stories that help bring primary care to life. So I asked Kurt Stange, a family physician at Case Western who practiced primary care for several decades, to tell us a story about a former patient of his, one that I think captures a lot about what primary care can and should be.
Jim Bauer and his wife Doris were patients of mine for a long time, and I saw them for various illnesses along the way. And one of the reasons I think we tend to think that primary care is simple is that a lot of things I saw them for were simple. I mean, Doris had high blood pressure, hypothyroidism, some arthritis, occasionally some anxiety. Each of those things were fairly simple. Finding a way to put the care all together was a complex and interesting function for her personally, but they were all by themselves simple. They were retired, and Jim came in to see me with a pain in his back, and he'd been out working on his automobile in his garage, and it looked like a muscle strain. It was between his scapula and his spine. So I prescribed some physical therapy, gave him some exercise to do, suggested he try some ibuprofen, and he did that, and it wasn't getting better. And he came in to see me a few weeks later. Just as I was walking by the room, I heard this, "Ah!" And so I skipped the next patient and went into the room, and he was saying, "That's it. That's the pain that I was having." And he had his shirt off, and I could see the muscle between his scapula and his spine there. I could see it bulging. He was having muscle spasm. So I pressed on it. I actually tried to massage it and make it go away, and it actually just made it worse. I just never seen anything quite like that. And one of the things you do as a primary care clinician is you use time as an ally, because so often things come in this undifferentiated state.
Stange went through the differential in his mind and, recognizing that it was pretty broad, decided to get a CT scan rather than to refer.
And the radiologist paged me actually and said, "You really got your money's worth out of this." And this was a while ago. This was when we actually looked at films on film. And I went down to see it and had him give me a copy. And I went home and had supper with my family, and then took it over to Jim's house that night and held it up and showed it to his wife, Doris. And I could see this large shadow. He said, "What's that?" "Well, that's your aorta. That's, takes the blood out of the heart to the rest of the body. And here at the arch, it should be a certain diameter. And it's actually 7 centimeters. And you have an aneurysm there. You have an enlargement there. And 6 centimeters is when you actually start to operate on it to prevent this catastrophic rupture. So we already had one that was a dangerous aneurysm. And we said, "And what about this?" And I said, "Well, there's this little thing on your kidneys. They just caught the top of the kidneys, not intentionally, but they caught the top." And I said, "Well, what's that?" "Well, actually, when you have a nodule like that in the kidneys, it's probably a kidney cancer." I actually don't think that has anything to do with your symptoms. And then he said, "Oh my gosh, is there anything else?" "Yes." And then there was this vague thing in the middle there in his esophagus. There was a thickening of the esophagus. "Well, what's that?" "It's probably another cancer." So that's why the radiologist said, "You got your money's worth." There were 3 things. So he said, "Well, what do we do?" I said, "Well, we need to figure out what this thing in the esophagus is. So I'm going to have you see a gastroenterologist. And I'd like to have you see a thoracic surgeon to look at the aortic aneurysm and think about that. And eventually I'll have you see a urologist, because you're probably going to need the kidney removed, but that's not causing you pain. And frankly, that's a slow-growing thing. It's probably not urgent. So we'll do that sometime." So I saw the gastroenterologist. It was indeed an esophageal cancer. I actually went with him to see the thoracic surgeon because he practiced in the same building as I do. And we talked about what to do about the aneurysm, which, the literature would say you should operate on this. That's 7 centimeters. But the surgeon said, "Well, there's about a 20% chance that where this is, that you'll be paralyzed. That will get rid of the blood supply to the spinal cord and you'll be paralyzed from it." Well, that wasn't very good. And you got this other thing. So why don't we hold off on that? And why don't you have Kurt do whatever he can to keep your blood pressure as low as you can stand it to avoid the stress on that. So we did that.
Under Stange's careful hand, Jim underwent treatment for esophageal cancer and what turned out to be renal cancer. Meanwhile, Stange kept Jim's blood pressure as low as Jim could tolerate and convinced Jim and Doris to start a walking program. The exercise seemed to both help Doris's anxiety and Jim's hypertension.
Primary care people do all that all the time. We try to focus on some simple thing and do it. But we're also trying to go back and forth between the parts, this little narrow thing, and the whole. That iteration going back and forth, it's hard to understand. The idea that you would be putting the pieces together. And I think we just don't understand that sometimes doing good enough on a lot of different things over time, but the right things at the right moment over time is great. So we try to do great for all the little parts and add them up and put them into a whole. We just don't have a way of understanding that role. And so in trying to improve the parts of primary care, we're actually killing the whole thing.
I wanted to understand what Stange meant by how, in trying to improve the parts of primary care, we killed the whole thing. So I asked Rebecca Etz, a cultural anthropologist and professor of family medicine at Virginia Commonwealth University, to give us an example of this atomization of primary care.
There was a great example of this when we had a nationwide effort to focus on hypertension. And we said nationwide, we have good evidence, guidelines that tell us a systolic pressure of 130 or under is a good thing. So make it so across the land, everybody has to be at a systolic of 130. And there was a paper that came out about a year after that national guideline was created that showed that hospitalizations related to hypertension went down 30% in the year that this new guideline was created. There was a follow-up paper that didn't get nearly as much fanfare that happened maybe 4 or 5 months later that showed during that same time period, hypotension or hospitalizations for hypotension went up by 30%. Because it turns out that guidelines are guidelines for a very specific condition and a very specific purpose. And they do not take into account competing demands.
Unfortunately, there have long been efforts in this country to distill primary care down to individual parts that lend themselves to standard algorithms. The metrics that have been applied tend to focus on particular diseases or risk factors for particular diseases, which is reasonable in theory. I would never argue, for instance, that controlling blood pressure or diabetes is unimportant. The problem is that primary care is actually about so much more, and placing so much attention and accountability on these individual parts can come at the cost of the more elusive and unmeasurable whole.
So if most of the time what you see is not something that has a diagnosis, then how do we say 100% of the time we're going to hold you accountable to disease-based guidelines? It doesn't make sense. And if we know that social systems account for 80% of your health, why would we hold doctors 100% accountable for population health outcomes? Why is my doctor held accountable for whether I'm obese or not? She is not here every day checking what I eat or if I exercise. Yet somehow that doesn't matter. She is graded based on the BMI of her patient population. This makes no sense to me.
It doesn't make sense to me either. And in our quest to address misunderstandings about primary care, I think it's really important to be as clear about what primary care can do as we are about what it can't. So I asked Elizabeth Bradley to talk to us a bit about some of the seminal work that she's done on the role of social determinants of health in determining population health outcomes. We all know by now that social determinants affect health. But what role can the healthcare system, and specifically primary care, play in meaningfully addressing factors like poverty, education, or poor nutrition? Bradley's currently the president of Vassar College, but 12 years ago wrote a book with her colleague Lauren Taylor called The American Healthcare Paradox. The book's the best work I've seen getting at this tough question about accountability for population health outcomes. Like many, Bradley and Taylor had observed that the U.S. was spending a far higher percentage of our GDP on healthcare than other countries. So why, they wondered, were our outcomes so mediocre in comparison?
Our maternal mortality rates are 6-7 times that of Sweden. Our low birth weights are much higher. Our diabetes much higher. Accidents much higher. Suicides, injury. I mean, it goes on and on. Chronic disease, infectious disease. Our outcomes are just bad compared to the world, particularly other high-income countries. So that's a paradox. How could you spend so much and not really get anything for it or get as much for it? And what the book concludes ultimately is that we are spending a lot on medical care, but we're spending very little compared to these other countries that are doing well on some of the social determinants of health. These would be housing, childhood education, proper nutrition, ability to have good exercise areas. All those pieces really make up our health. We're kind of underspending on. And we did an international comparison and saw again and again those countries that were getting high, good public health outcomes were actually spending much more evenly on medical care and social determinants. And we're very heavily invested on medical care and underinvested in social determinants.
She went on to describe how these findings play out, not just internationally, but also across the United States.
We ended up replicating that study, which had been done internationally, on the various 50 states in the United States, because that is an incredible laboratory to experiment in. And our states are very different in their spending. Some spend very heavily on medical care and not so much on social services, and some are different. And we found the exact same pattern holds, that those states with really strong health outcomes have a much more balanced portfolio of investments between medical care and social services, and those states with very poor outcomes are really underspending on the social services.
Given that some seem to believe that the health system should be more actively invested in addressing social determinants of health, I asked Bradley whether when writing the book, they anticipated this potential shift in responsibility from various social sectors to the medical system.
Yes, I think the point you're raising is critical, and we've given this a lot of thought, because some people have taken the implication of the book to mean just slap onto the medical care system, you need to worry about this person's depression, housing, loneliness, food insecurity, and that they have nowhere they can exercise. Impossible. Primary care is already totally overwhelmed. It is impossible to just stick that on the medical care system and go do it. And there are other reasons too. Medicine's whole value and whole mantra, it's heavily scientific, it's heavily measured, it's heavily objective. People go to school for a long, long, long time to be objective. Think about that compared to social workers. It's really meet the patient where they are. Think about all things, be connected to the family. Like, they're just two different jobs. And we need both jobs. So actually, when the implication of the book was just slap the responsibility in the medical care system, we were very worried about that. We thought that actually is not going to work. It's just going to burn out primary care. People are going to leave. There'll be a lot more bureaucracy. And the actually good medical care will be compromised by having to basically spend all one's time making phone calls to figure out, how does this person get food every day? And they're not trained for that.
They're not. And basically everyone in primary care I interviewed argues that primary care needs more resources to help patients access social services. But in terms of tracing the roots of this impulse to hold PCPs accountable for outcomes often driven by social circumstances, I suspect it actually arises from an important recognition that just got lost in policy translation. And that recognition is that a person's life circumstances are as essential to understand as their medical. Family practice in particular has long been oriented toward integrating the social and the biological. Here again is Rebecca Etz, the cultural anthropologist.
We often call back to Gail Stevens, one of the founders of family medicine, and he wrote a wonderful article that talked about family medicine as counterculture. And since it was in the late 60s, early 70s, everybody thinks they know what he means by counterculture, right? And they're like, oh, it was the 70s, everybody was a hippie, and of course it was countercultural. And that's not at all what he meant. What he said was actually really radical, and it was that what makes family medicine unique is that it holds social experience and social information in equity with scientific information. It holds your biography and your biology as both equally important and part of a coherent whole. And the only way we can understand you is to pay equal amounts of attention to both. And before that, it was all about the scientific method. It was drill down on the pathology, isolate, predict, control. And family medicine is not about that. It's about understanding how we live has everything to do with how we experience health and illness. And you need to understand both how we live as well as the biology of the organism in order to help us.
Listening to Etz and Bradley together helped me better understand not just how primary care has been misunderstood, but why. As Bradley pointed out, medicine's heavily scientific and heavily measured. That's true, and in many ways for the better. But family medicine, and by extension, I'll include all of primary care, has this additional dimension that I think often defies measurement. Some of that dimension is the integrative function, the putting it all together that Stangy talked about. But what allows that integration, and what really sets apart the nature of expertise in primary care, is that that expertise, at least theoretically, is inextricable from the relationship. Does that mean other physicians don't have relationships with their patients? Absolutely not. I think that would be a ridiculous thing to say. But I do think so much of what's been misunderstood about primary care, especially in this quest to hold physicians accountable for measurable outcomes, is the centrality of these relationships and the need to create a system that's built around supporting them. What we have instead is largely the opposite. And the tragic irony of this atomized technocratic approach to primary care is that the fewer people who have an actual relationship with a doctor, the worse our population health outcomes are likely to become. Yet rather than invest in a primary care system that supports these critical relationships, its funding only continues to decline. And so I started to wonder whether primary care has been dying for so long that we all just assume it can survive anything. And so I asked Etz whether at some point primary care becomes such a shell of its former self that it's just too hard and maybe too late to save it.
Absolutely. I actually wrote a commentary with Chris Kohler that we called Too Critical to Collapse. And I had exactly that in mind, right? Nobody believed that any banks would close. It wasn't even within our imagination. And then suddenly Bear Stearns one day was gone. Suddenly Lehman one day was gone. And nobody thought that could happen. It can happen, and it would be devastating when it does. What would it mean for us? It means that we would have health diseases suddenly become deadly when they need not be. It means that health burdens would increase, and our means of taking care of those health burdens would be limited to only the most expensive options available to us. And I struggle with this a lot because I've been doing this for a while. And especially during the pandemic, it was like week after week after week of sharing. Practices don't have PPE. The clinicians are dying from COVID because of exposure. They're not getting any money and they're having to close because they are continuing to deliver care even though it's not being reimbursed. How long do we have to keep telling that story? The National Primary Care Scorecard has shown now for the third consecutive year, payment going down, size of the workforce going down, access being harder and harder to get, people having a usual source of care being a rarer and rarer thing. And I think about the report that I worked on with 20 or 30 others at the National Academy of Sciences and Engineering and Medicine, published in April 2021, implementing high-value primary care. It's got a chapter in it that shows all the evidence, 40 years of evidence of the kind of good that primary care can do. The benefits that sustaining an adequate workforce can have on mediating social inequities such that they don't become in health inequities, preventing conditions, limiting the amount of burden created by health conditions, limiting the total cost of care on the population. And I have to ask the question, for how long do we need to collect the data? And how much data do we need to collect before somebody actually listens? I don't know.
It's tough to exaggerate how much I thought about this question in the last year. And I think the data disconnect is no different than the definitional disconnect. meaning it's become clear that neither is an effective tool of persuasion. We spent the whole episode talking about how primary care has been misunderstood. But if I were to read you again the definition from the NASM report, does it make it any clearer? Does it make you want to go advocate for primary care? This isn't a criticism of the definition, nor is it a criticism of the report. It's more a question about whether the tools we reach for, like generating NASM reports, are the right ways to affect policy change. Indeed, the explicit task for the authors of the 2021 report on primary care was to create an implementation plan for the recommendations made in the report in 1996. And why was that? Because with few exceptions, no one listened. We've been having this same conversation for over 25 years. So are there better ways to help people understand primary care well enough to fight for it? I asked Stangy what happened to Jim Bauer.
So he lasted another 3 years. Every time he went into the hospital with back pain and with his blood pressure up, we thought it was going to be his aneurysm rupturing. What didn't happen, he did okay. He had horrible reflux, but kind of managed to tolerate that. And then one night, he, I think, fell off the pillows that he used to prop himself up when he slept. And his wife woke up and he was shaking next to her in bed. And she actually called my house. And I was away on a trip to England. And my wife answered the phone and told her to call 911, which he did. And he was in a bad shape. And so they had to take him to the nearest hospital, which is not the hospital where the person covering for me was on staff. And so he was admitted to the ICU, was taken care of by strangers, was basically brain dead, but was resuscitated. And it turns out his aneurysm was fine. I don't know what happened for sure, but he probably had horrible reflux and aspirated or something. But there he was surrounded by strangers. He had neurological consults and was declared brain dead and was taken off respirator, and he died. You never know. I still wonder, one of the things that you hope you can do with this investment relationships over time is be there for people at critical moments. And, I wonder if I'd been there, if we could have maybe just stopped right there, not resuscitated him, not intubated him, not dragged him to the hospital. I don't know.
By the time I had Stangy on the podcast, I'd read the story about Jim Bauer multiple times, but I still found it incredibly moving when Stangy told it to me directly. I'm trying to figure out in myself what is so moving about it. I mean, obviously, it's a human who has multiple illnesses, and that alone is moving, and his relationship, their relationship to each other. But I think what really moves me is just that you're a doctor. Like, you are a doctor in the way that I imagine being a doctor can be. And it feels like you're a vanishing breed. And I'm almost like, I'm embarrassed that I feel the way I feel in some ways, because it feels nostalgic. It feels almost like I'm longing for something that can no longer be, or out of touch with reality. And I'm wondering if that's something that you perceive as you watch the workforce evolve, and if you think that your way of practicing is sustainable. Because where I am, and I can imagine if I were indeed the primary care doctor, I would have leaned harder on the specialists than you did. Like, just the mere fact that you went with him to see the surgeon, that's a beautiful thing. And I'm not sure that many people practice like you do anymore. And so I'm wondering if you think it's truly impossible to be that way, or whether there's anything we can do to make more people like you, because I don't think the problem is a lack of intelligence or interest in the workforce.
Well, I don't go to all my specialty visits with my patients. That it happened to work out logistically there. But that was an investment because that was an important relationship for Jim and an important relationship for me. And the surgeon and I did a great job together caring for that patient because I was able to go there. I only stopped in for 5 or 10 minutes during the visit, but it really helped a lot. So I think, and you're a specialist, you come from a medical family, but this is what you try to do too. I think we all want to personalize care for our patients. We have a lot of discrete knowledge. We know the literature on what works on average. But what makes it interesting and meaningful is to say, what does this person need in this moment over time? And so I think we all do that. We all want to do that. We all decry how commodified healthcare has become. that we feel like we're delivering these little commodities of care. We're like line workers. So I think that everybody that goes into primary care wants to do this, wants to take care of the whole person, wants to invest in relationship, and do it. I think that the system makes it so hard to do that, that you have to choose when you invest in that. When you can just kind of do the minimum, and when this is when it's really going to make a difference in this person's life. And I think we all do that some. I think we'd all like to be able to do it a lot more.
Doing it more will require a massive reinvestment on the part of our healthcare system. But it also requires continuing to attract talented physicians like Stangy, who have the intellectual and emotional capacity to do the hard work of real primary care. And yet, trainees are increasingly walking away.
I think the biggest piece that I had a hard time reconciling is this concept of trust in primary care and how hard it is to replicate that experience or really get insight into that experience as a resident primary care doctor. I think just from the get-go, you're inheriting a panel of patients who have previously been cared for by resident primary care doctors for the most part. These patients sort of get passed along through different residents for many, many years. And I think some patients don't mind that. And I think a lot of patients, especially those who are medically and socially complicated, start to develop a little bit of wariness about you being the next person in a long line of people who have just been around for 3 years and then move on.
That's next up on Not Otherwise Specified from the New England Journal of Medicine. I'm Lisa Rosenbaum. Our editor is Debbie Molina. Our producer is Mary Rose Madden. And Adam Strauss is our audio engineer. Blue Dot Sessions supplied our music. And I also really want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me conceptualize this season and identify the most pressing and unexplored challenges facing primary care. My new article series on primary care can be found at nejm.org.